Jamie and Andrew, it's really great to see you both here at the ASH 2024 annual meeting in beautiful, sunny, warm San Diego, as opposed to the places that we all flew in from in the last couple of days. And I'm excited to be here with you to talk about an issue that we all think about and manage a lot in our practice, which is myelodysplastic syndromes, and with particular attention to the luspatercept era and how we are approaching our patients now, reflecting on ESAs, what we've done historically, what we're doing today. So there's a whole bunch to talk about. We have 4 papers or abstracts to go through, so we can get into that content in a moment. But why don't we just start with some quick introductions. I know we all know each other, but not everybody watching necessarily knows us, and we don't know who's watching. So I'll just say I'm Tom LeBlanc from the Duke Cancer Institute, mostly see and treat patients with acute leukemias and myeloid diseases. Do you want to go next, Jamie?
I'm Jamie Koprivnikar. I'm at the John Thur Cancer Center in Hackensack, New Jersey, at Hackensack University Medical Center, and I have a very similar practice to yours, primarily treating leukemias, MDS, and bone marrow failure.
And I'm Andrew Brunner. I'm up in Boston at Massachusetts General Hospital, and my primary focus is really early phase trials in myelodysplastic syndrome, but similar to you both, I treat a broader spectrum of myeloid neoplasia as well.
So in talking about and thinking about low-risk MDS specifically, which is our focus here today, we all experience this challenge in our clinic where generally patients are symptomatic from their anemia. It's by far the most prevalent issue in MDS. We can transfuse patients to help them feel better. Often that's not enough, and of course that's very involved and difficult for people for a lot of reasons. Tell me a little bit about your thoughts on this first paper that we have to discuss, which is about a real-world study from the Florida Cancer Specialists data set, looking at what we've come to expect and see historically with ESAs in low-risk MDS. You know, how well do they work, how long do they work, et cetera. Jamie, do you want to get started with this one?
Yeah, absolutely. So we saw that response rates are actually not good at all. What really surprised me about this paper is the duration of time that patients spent on ESAs when they were clearly ineffective.
Yes.
So obviously a lot of healthcare resource utilization, going toward this largely ineffective therapy, and then also not to mention, the patient's sort of burden of receiving these injections, showing up to clinic for a therapy that's really not working. So I thought that was one of the most striking pieces of that particular paper.
Absolutely. I think it's really reflects the challenges that we've had up till recently in lower risk MDS, where on the one hand you could offer somebody an injection that was easy to give, that may not work for many people, but had a very well-tolerated side effect profile, very unlikely to cause much toxicity. And suddenly, if that didn't work, where could you jump? You were looking at maybe considering lenalidomide in combination. You were looking at maybe considering treatment that you might use for higher risk disease like azacitidine or decitabine, perhaps at a reduced dose. But it created this really big chasm of therapeutic options between starting somebody on some treatment for their anemia and then jumping into really chemotherapy-based treatment. And I think that was, and this paper, which was about 250, 270 patients treated in community practice, really reflects that challenge, that problem, that anemia, the burden of anemia on most patients with MDS. I think it's also reflective of the majority of patients with MDS. Most of them are in the community. Most of them are being seen locally. Most of them have predominantly anemia. And to me, this paper illustrates that there's a lot of room to grow. We have a lot of room where we can improve with new therapies in that group.
Yeah, so these are all really interesting, great points you're making. It strikes me that we haven't had enough options for these patients for the length of time that they suffer with this disease. And thinking about what we've learned from risk stratification schemas like the IPSS-R or now the IPSS-M, patients with the lower risk myelodysplastic syndromes, if we kind of lump those together, they might live 5, 8+ years. And yet, even those who have a response to exogenous EPO, on average, might benefit 6 to 18 months or so, and it looks like that's what bears out in this FCS paper, unfortunately. So it's what, 30% or so getting a significant response, and then maybe 6 to 18 months duration. What are we going to do for the rest of those several years on average that these patients live, when most of them thankfully won't evolve to AML? I try to avoid giving chemotherapy to patients with low-risk MDS.